cause a woman who has osteoporosis. But it's a silent disease because osteoporosis isn't the problem, it's the fractures that come because of it. And we call them fragility fractures because the bone breaks more easily. Sometimes as easy as stepping off a curb and somebody will break a bone on their foot because their bones have lost their mass. And what's really frightening is a single fracture caused by that increases the risk of another one by 10 times. So that's the number one predictor of somebody having fractures because of osteoporosis. And there's some data. It's a combination of age, with bone loss with age, but also as people get older, even the same amount of bone loses its strength. And so older women who have less bone and poor bone quality are at the greatest risk. And then you see that the 80-year-olds in the upper line, even when their bone mass is pretty strong, are still more likely to get a fracture than somebody who's younger. So, purpose of bones. Amount of bone loses its strength. Skull protects our brain, and ribs protect our lungs and our heart. And also, obviously, to move. And also metabolic. I'm not going to talk about the metabolism, but we store calcium in our bones, and calcium is important for many, many metabolic activities. So if you need extra calcium, you can pull it out of your bones. And so older women who have less bone and poor bone quality are at the greatest risk. And then you see that the 80-year-olds in the upper line, even when their bone mass is pretty strong, are still more likely to get a fracture than somebody who's younger. Through the first 30 years or so, amount of bone loses its strength. Skull protects our brain, ribs protect our lungs and our heart, and also metabolic. I'm not going to talk about the metabolism, but we store calcium in our bones, and calcium is important for many, many metabolic activities. So if you need extra calcium, you can pull it out of your bones. And so older women who have less bone and poor bone quality are at the greatest risk. And then you see that the 8-year-olds in the upper line, even when their bone mass is pretty strong, are still more likely to get a fracture than somebody who's younger. Through the first purpose of bones, amount of bone loses its strength. Protect our lungs and our heart. And also metabolic. I'm not going to talk about the metabolism, but we store calcium in our bones, and calcium is important for many, many metabolic activities. So if you need extra calcium, you can pull it out of your bones. And so older women who have less bone and then you see that the 8-year-olds in the upper line, even when their bone mass is pretty strong, through the first many metabolic activities. So if you need extra calcium, you can pull it out of your bones. And so older women who have less bone and then you see that the 8-year-olds in the upper line, even when their bone mass is pretty strong, if you need extra calcium, different whole family of bisphosphonates that I'm not going to talk about today. Calcitonin and then a bunch of other biologics that target specific genes. And then only a couple of things that actually will build extra bone as opposed to slowing down bone loss. And this is some of the first data that we had. This is back in the mid-1990s. Demonstrating that hormone therapy, which are the upper curves, and we typically look at spine because that's the fastest bone turnover, and that's where most fractures are going to happen in the spine. Why women start to bend over because they get fractures in their spine. And as I mentioned, hip because that's the most morbid, one of the most dangerous fractures. So we look at both of those. In both those, they demonstrated that hormone therapy actually, you get a little increase in bone density with treatment, and then the lower white line is where there's no treatment. So it's clear that estrogen hormone therapy can help slow down that actually, for a short period of time, actually build back some bone. And this is comparing it to the number one treatment for bone cancer is the bisphosphonate agents, which help do the same things, slow things down. And it shows here in the black line is hormone therapy and a whole, but it's kind of a compilation of different bisphosphonates. So basically, they do the same thing in terms of just as effective in terms of anti-resorption. And that's a really important concept because you can use them equivalently depending on what the other circumstances are. And we knew at around that time that hormones could affect things like vertebral fractures, but we didn't actually have data that it prevented hip fractures until the Women's Health Initiative first came out in 2002, and that was demonstrated that we actually could prevent hip fractures, about a one-third reduction in hip fractures with hormone therapy. And so it's been very, very strong data. So we know that this works. And this is and it's a cumulative effect over time, so the longer that somebody's on it, the more benefit that she's going to have, because it slows it down. And remember, bone loss is a slow, steady process over a long period of time. And so the benefits clearly of hormone therapy, we know that there's improvement or maintenance of bone mass, prevention of fragility fractures, and if somebody has symptoms like hot flashes or vaginal dryness, it's a treatment for that too. And that's the other major use of hormone therapy at the time of menopause. And again, we don't have time today to talk about, that's a whole big, huge topic by itself. Not quite certain about some other things, but there's some thought that it might actually help reduce risk of cardiovascular disease and maybe dementia. At least there's some hope in that line. But the risks, and this is the reason why there's concern about using hormone therapy in everybody. We know that there's an increased risk of deep venous thrombosis and pulmonary embolisms, especially with oral therapy, which is the traditional way to give estrogen. And that's a significant concern, about a 50% increased risk over the background rate. Fortunately for most people, that's a low background rate, but it still can be significant. There's also, again, with WHI, increased risk of breast cancer with certain forms of therapy. There's bleeding and spotting problems, and believe me, for women who have stopped having periods, last thing they want is to start having bleeding again. So we know that, and all the gynecologists in the room know that too. And the risk of endometrial cancer if you just give estrogen in somebody who has a uterus and don't do something to counteract the effects of that estrogen. So we have to know how to provide this therapy. The other thing that's important for menopause therapy, it has to be systemic. And so giving somebody a topical estrogen isn't going to help because it has to get to her bones. So it has to be systemic. But it turns out that low doses are relatively effective in providing anti-resorptive therapy. In general, it takes more to treat somebody's hot flashes than it does to maintain her bones. So you can actually get by with relatively modest amounts of estrogen for bone health. And as I mentioned, non-oral therapy has a much lower rate of thrombosis, and so for midlife women and beyond, clearly that is the strategy of choice to reduce the risk. So, due to that risk, the initial recommended therapy for osteoporosis prevention and treatment is bisphosphonates if somebody doesn't have any other menopausal symptoms. Standard current therapy, that's frontline therapy. But in the presence of any menopausal symptoms, anything else, so you're going to treat two different things at the same time, hormone therapy is absolutely accepted as an alternative therapy for osteoporosis prevention and therapy. And so it needs to be on everybody's list, and they need to be comfortable in being able to provide it for those women where it's appropriate. And so this is my current favorite regimen. I totally own this one. There's one of many. There's many ways to provide therapy. The best data we have for non-oral therapy is transdermal patches. They're certainly available here. They come in many different doses, and so there's lots of flexibility in dealing with them. Absorption is great, and the clot risk is actually quite low. And you can adapt the risk to treat the other symptoms, and so the doses can be whatever they need to be. If somebody has a uterus, in the US, about 40% of women don't have their uterus by the time they get to menopause, so not everybody has to be on this. Some kind of progesterone. I tend to use micronized oral progesterone, but there's many other options for that. And you can do it either every day or in a cyclic fashion, and as infrequently as every 3 months is sufficient for safety. And people say, well, how long can you do this? I think as long as somebody has symptoms, we can provide the therapy. There is no absolute ceiling to that, so there's no absolute age limit. So my take-home messages, and I know I've probably gone over my time, I apologize for that. Estrogen has a direct effect on bone turnover. Bone mass declines from mid-adulthood, we know that. Menopausal decline in estrogen is associated with accelerated bone loss. As estrogen goes down, bone loss accelerates. And MHT can slow bone turnover and loss of bone comparable to other anti-resorptive agents, so it's on our... It's okay, I'll talk over them. And then finally, menopause hormone therapy prevents fragility fractures, and we have good data to demonstrate that that's true. And with that, again, thank you all for your attention and your hospitality. It's been wonderful.
Fantastic. It's quite a great job.
Can I pass this?
Anyway, I was not expecting the professor to be this short because I know the magnitude of the subject, but thank you very much, Professor, for being this short. And as you can see, we are being shared online around. There's so much interesting to see how things can be. Now, gynecologists and obstetricians are so short-sighted. We believe that everything ends within our area of concentration and everything. We don't know that surgeons deal with menopause. Professor Alex, tell us about it.
Thank you very much.
Thank you very much.
Put this right on. Yeah. Good afternoon, ladies and gentlemen. It's a great to be around here and present on a very important topic because every single person seated here or standing had to go through 9 months of being carried by a lady. My presentation will be on bone health and menopause. The orthopedic surgeon's perspective. So, orthopedic conditions associated with menopause, osteoporosis, that's what we concentrate on, and that's what most people know. Osteoarthritis is very common. Another aspect not usually associated, people don't really give it a lot of energy. And sarcopenia, and age-related involuntary loss of skeletal muscle and strength, forgotten by many. Because if we look at the blood supply of bone, when there is no muscle, the bone supply is poor. So they go together. So, a very nice definition was given before, and I reduced bone strength due to deteriorating bone mass and a microarchitecture leading to increased susceptibility to fracture. So, if I would compare, if you look at a very nice, well-made bread, and the one where somebody wanted man and put in a lot of gas, that's a normal bone versus osteoporotic bone. Females have a greater risk for osteoporosis compared to men because of lower peak bone mass. So what should we do? If you have a daughter, if you have an aunt, before they are 30 years, please try to give them enough calcium, enough vitamin C, enough vitamin D to build the bone, and a good exercise. Menopause causes faster loss of bone. Already there was a bit of a deficiency, and now you're even going to lose it faster. Osteoporosis, what belongs to everybody but belongs to nobody. So the orthopedic surgeons know they are not doing what is necessary. The radiologists see it, they are not doing what is necessary. The gynecologists who actually should be they are doing the same thing the orthopedic surgeons and the radiologists are doing. So it's a wake-up call. And thank you for bringing a very important topic. So, as the earlier said, osteoporosis is asymptomatic, but ultimate consequences, you get a fragile fracture. it poses a tremendous medical and economical challenge. Because if you look at the number of beds occupied by people who have fractured neck of femur, people who cannot walk because they have distal radial fractures, and the amount of pain they go through, I think prevention is better than cure. It is a problem to patients and the society. And despite the availability of effective therapy, substantial number of patients remain untreated. Traditionally, if you look at its pathophysiology, traditionally there are two models. In females, there is estrogen deficiency in postmenopausal women, and in the elderly, secondary hyperparathyroidism due to menopause and vitamin D deficiency. In reality, osteoporosis is a multifactorial disease caused by a complex interplay of genetic, intrinsic, exogenous, and lifestyle factors. Here, they talked very well about osteoblasts, bone building, newborn and existing bone, osteoclast, bone remodeling, mediate bone loss in pathological conditions, and increased bone resorptive conditions. These osteocytes are actually, they are highly specialized in nature. They are there to maintain bone matrix, which is biomineralization. You know, if there is no mineralization, then the architecture of bone is gone. So, the very cells we are talking about, bone remodeling. It's governed by osteoclasts, osteoblasts, and osteocytes. And we know these are derived from stem cell lineage. So osteoclast differentiation is stimulated by LUNKED, that's the receptor activated nuclear factor kappa B ligand, and microphage corn-stimulating factor. Whereas osteoclasts, it is the osteoprogesterone and DCOF1 and which actually help in sensitizing of osteoblasts. So if we look at this, you went through the same process, actually, resorption, reversal, formation, and the kinesis. So depending on, we know when we talk about apoptosis, it is like when we talk of senescence, every cell has a time to go. So there are macrophages ready. Osteoblasts will put new bone when we are losing the other one. There is a period when you are a bit stable, and then, as we said, when the eating is more than the building, you lose the bone. So it's a process. It is coordinated delicately to maintain bone mineral homeostasis and strength. Bone loss occurs when bone formation is lower than bone resorption. What are the factors which influence this process? Estrogen deficiency, inflammation, and oxidative stress. And we know very well the last two are a bit embedded in people's lives. So they skew the process towards the catabolic direction. They serve as a basis for bone loss in many pathological processes. So very, very important. Actually, estrogen is as important as the 1% you people are concerned with. Very important, very critical, and very outstanding. So if we look, all of these, you know, tumor TNF, interleukin 6, interleukin 1, those are pro-inflammatory cytokines. When you will look at osteoclasts, they will use those. When we talk of apoptosis, that is cell loss. So, estrogen deficiency, I just think because he has talked about it, when there is a cessation of ovarian function, bone loss starts during menopause due to an increase in saturating FSH. It also explains the age-related loss in elderly men. Androgens converted to estrogen via aromatase enzyme exert bone protective effects. It has been replicated in female castrated animals through osteoblasts, osteoclasts, and osteocytes. Increased osteoclast differentiation and survival. So, estrogen deficiency causes opposite effect on osteoblasts and osteocytes, so we don't have who are to build. Epidemiological studies have shown And the other one is the inflammation and oxidative stress. It has shown that it increases pre-inflammatory cytokines production by peripheral blood mononuclear cells without comorbidities. You don't have to have any problem. So this is an intact femoral rat. This is a castrated femoral rat. You see it has lost bone. Castrated femoral rat treated with laloxfen. So if we look at inflammation, we all get inflammation on a daily process. So it has a central role using CD4-1 cells and the Th17, which secrete the pro-inflammatory cytokines we are talking about, interleukin-1, interleukin-6, interleukin-17, LANKEL, TNF, interferon gamma. All these things, when you have been in ICU, you know what it means. They produce osteoclastogenesis, or breakup of bone. So if you look at all this, they facilitate the breakage of bone. If the other mechanism is not working and they work unopposed, you lose bone, and we also said we lose muscle. And that's actually why when you meet some old men, some of our dads and everybody, when you're young, you put on a size 52 or 50, without knowing you are losing your belly. So people start seeing actually you have a problem because you didn't realize that you need to go from 50 to 48. It's something very important. Yeah. So other cells with the higher pro-inflammatory and pro-osteocalagenic properties are CD4 plus CD28 T cells, and the beta cells which are actually found in the marrow, and they go through the LANKEL and MSF4 systems. So something very important, inflammatory induced osteoporosis. There is, where the gut and the bone and the brain play a role. So the gut microbiome is related to bone health. Patients with osteoporosis show an increased abundance of actinomyces, Egrethera, Clostridia, and Lactobacillus. How do they regulate the bone modeling through this mechanism? Activation of lymphocytes and inflammation, influencing bone hormone and nitric acid levels, altering metabolism of vitamin D and calcium absorption. We all know vitamin D is central to this. And that's actually why every one of us should get a few minutes at around 10 a.m. in the morning and get his share. Or her share. Thank you for that. Immune system is playing an important role in mediating bone axis and may lead to targeted therapies. People are now doing research to see how we can use that. It's already working in autism, anxiety, depressive disorders, and irritable bowel disease, but more research is still needed. Osteoporosis, if we continue with the oxidative states, free radicals via aerobic respiration. Under physiological conditions, antioxidant system protect us from harmful effects of free radicals and oxidants. You are in a constant fight with this. But if they are overwhelmed, this is the pathogenesis of various diseases, including osteoporosis. More studies to this may give us good answers. Saturated levels of endogenous antioxidants, uric acid and bilirubin, have been associated with BMD studies. Dietary saturating antioxidants like vitamin E and C are associated with positive BMD studies. What are the risk factors here for osteoporosis? Cigarette smoking, excess alcohol consumption, they go through the oxidative way. That's how people lose that. So detection and diagnosis of osteoporosis. I will not dwell very much because somebody might be entering his field, but the T-score, which is based on BMD, we may use DEXA scan. We look at the femoral neck and the spine. Here we'll just talk a bit about it. The human being a bipedalist, that's why we have eyes here, so that we have about a 270-degree vision. Because we can turn and see our enemies. We are bipedalists, but what we have low back pain because quadrupeds animals don't have that. And the same thing In the same vein, we also get compression fractures of the vertebra and the fracture neck of femur, because when you drop a plant line from C1 through the L5S1 and it diverges to go through the head of femur, through the knee and through the talus, is actually a forced movement. And so, and remembering that, as you said, God being very wise, he put the brain here for protection. The heart and the other organs are protected by rib cage. The reproductive organs are protected by pelvis. The rest of the things, they can look after themselves. So these ones, he will talk about them on quantitative ultrasound. I won't talk. The low-dose CT scan, when you don't have a DEXA scan, he will talk about it. I think, actually, risk factor algorithm. We can use a FRAX. We adapted from the University of Sheffield. It assesses the risk of fracture, been validated in 66 countries, covers 80% of the population, but it has been adapted in many countries. It is helpful. I got a copy there. The risk factors, non-modifiable. These ones, I'm just trying to emphasize what he said. Age, female sex, ethnicity, a history of osteoporosis in the family, medical conditions, rheumatoid arthritis, hypogonadism, sorry for the spelling, chronic renal failure, cancer, medications like glucocorticoids, protein pump inhibitors, anticonvulsants, and anticoagulants. Modifiable factors, low birth weight, low body weight, you can actually add. Sedentary life, you can exercise. Calcium deficiency, you can take calcium. Cigarette smoking, you can leave smoking. Alcohol consumption, you can reduce. So, pharmacological factors, you went in detail. These are some of the things we use. For bisphosphonate, I did give an important issue when you are giving them. When you give them, you don't give them constantly. You have to give the bone a break, or otherwise they get very funny fractures. You'd think that somebody hit. Actually, you can imagine if somebody used an axe or a panga to cut very clean the bone. So that's the type of fractures you get with bisphosphonates. So if you give for 3 months, you rest 1 or 2 months, and then you give another. So surgical management, we use locked plates, because the normal plates, it doesn't hold. We use locking nails. Not the best. Sometimes we have to augment. This is very clear in vertebroplasty and the kyphoplasty in the spine. Prevention. Adequate calcium and vitamin D. That means you start very early. Use that 30 years when you're building up. Regular weight bearing and muscle strengthening exercises. We all know these exercises where people can exercise. They are very good, and you don't lose your muscle very fast. Then you don't lose your bone very fast, and you delay. We may not stop it, but at least we can delay it. This is like a death. And because the senescence takes you slowly until the end. Good food for bone health, avoid smoking, avoid excess alcohol, and thank you very much.
Thank you, Professor Alex. I think that if you had been a good gynecologist, we wouldn't have been giving you so much job. It has been terrible, But before it gets into your hands, to fix bones, you have damage, because you don't do good consultations and the prevention and everything. The radiologists have to see the damages with the machines inside there. That's quite interesting to see. Okay. People following us online, they're complaining that we're not clear enough. Please try to be giving the device. Now,